All right. All right, we're live. It is great to see you all. It is great to be here. I am Alex Bryden. My pronouns are she, her. I'm a technical director in the CMS Office of Minority Health, and it is my great pleasure to be moderating this panel today. In case you all are in the wrong room, it's measure what matters. So we're looking at variation in health equity tracking and measurement across healthcare systems. So even more sort of less words, more straightforward. The folks who are here today, who you're going to hear from, who are the headliners really, are working in the trenches every day at their organization, thinking about what their organization can do and is doing to advance health equity and how they can measure it. To assess, how far are they on their journey? What more needs to be done? What can they do? What can we all do? Given limited resources, given time and energy available, how can we optimize and maximize and make sure we're making the right choices and looking at things that our organizations can all consider sort of intentionally as we think about how to advance health equity? So that's my topper. I've got a couple of folks here sitting up here, and I'm going to turn it over very briefly, very quickly to Kristen and Carol, who are going to give a sort of overview. Carol's right there, so she's not with me. And then after they do their overview, we're going to go into a moderated Q&A that's going to be a little bit like sort of between two ferns style, where we're going to hear from all of the panelists, answering some of the questions that we hope resonate with folks here today and in our live stream. At the end, we'll have a chance for folks to ask questions live in the audience and on the live stream coming in from the virtual space. So that's kind of what you can expect. You're not going to hear that much more from me. So with that, I will turn it over to Kristen and Carol and let them take the stage.
Thank you so much, Alex, and thank you all so much for coming to the panel today. My name is Carol Kapaski. I'm a principal on Vizient's intelligence team. And just for context, Vizient is a member-owned performance improvement company serving over 60% of the nation's acute hospitals and their affiliates. In late 2020, Vizient conducted a SDOH benchmarking survey of its member health systems to better understand key components of health systems' need to assess and address social needs and risks within the health system, as well as in their community partnerships. When the results were shared with the Vizient Health Equity Network, which is a group of senior clinical administrative executives at member health systems responsible for overseeing health equity strategy, leaders observed that the survey left unaddressed an interrogation of health equity metrics, performance targets, and practices to monitor accountability. Of particular interest was how this information is presented and used by executive level leaders. And then in spring of 2022, the Sutter Institute for Advancing Health Equity collaborated with Vizient and UCSF to release a cross-sectional survey to assess just that, as well as inventory existing system level operations and identify barriers and facilitators to implementation. The survey was distributed by email to current members of the Vizient Health Equity Network, at the time representing 132 member hospitals and health systems between April and June of 2022. 27 health systems responded, representing a diverse geographic sample you can see on the screen here. And of note, 100% of respondents also indicated that they collected self-reported race and ethnicity data. And Kristen, I'll pass it to you to share the survey results.
Thank you. We primarily use descriptive analysis to summarize the survey results. Health system leaders were asked to indicate the stage at which their institution was in implementing health equity metrics and KPIs on their executive level dashboard. And more than half were in the planning phase or early implementation stage. This is important to note given that the people who responded to the survey were likely early adopters of these practices. Also, 26% of institutions indicated that they had a formal department specifically dedicated to health equity in their health system. It's important before we go on to define what we mean by an executive level dashboard. This is a business monitoring tool used by the chief executive officer at a health system in terms of administrative leaders to monitor top-level key priority indicators. We recognize there are a lot of different types of dashboards and scorecards that get implemented within health systems and different departments, but we really want to focus on the highest level tracking for leaders of a health system, and so the highest priorities. In terms of reporting practices, systems were asked to identify what types of dashboards they used at the executive level to monitor health equity metrics. We also refer to these as KPIs, key performance indicators, in case there are some that are not familiar with that term. And the respondents were able to check all that apply, as well as indicate an open-ended other response. Most reported tracking via healthcare system level and or enterprise level dashboards that they sometimes refer to as a scorecard, about 81%. About 2/3, again, you can select all that applies, so they're not mutually exclusive categories. So about 2/3 of the health systems monitored health equity related KPIs via a system level POP health or population health dashboard. The survey then allowed for the entry of each metric individually, along with a selection of sociodemographic filters or filters used to evaluate a potential disparity, with an open-ended other opportunity as well. Across all implementation phases in all health systems, systems tracked on average 4.1 metrics. When examining by implementation stage, the mean number of health metrics tracked was less for systems that were at later stages of implementation. Apologize for going forward here. I think I advanced too quickly. So you can see here the information that I just presented. And it's really important to note that we noticed this decrease in number of metrics tracked with implementation stage. And we'll get into that in a minute in terms of areas that we want to understand more fully. So across all health systems, there were 113 unique metrics mentioned in the free text fields. The most frequently reported metrics related to preventive care and chronic disease management, and this was 22% and 16% respectively. Common metrics in preventive care included cancer screenings, mental health screenings, well child visits, and immunizations. And diabetes and hypertension were the most frequent focuses of chronic disease management. Other metrics were categorized as related to acute care, about 15% of mentions, patient experience, which was about 12% of mentions, utilization and readmission, about 10%, and other social needs, for example, food insecurity or housing insecurity. The metrics categorized as acute varied, but mostly they were different types of mortality indicators. In the review of sociodemographic filters used across systems, there were 243 filters in terms of mentions across those metrics that we asked about that were used overall across all the metrics mentioned and were intended to evaluate and compare equity and address potential disparities between groups. Race, ethnic group, or subgroup was the most utilized, as this filter was used 104 times. So about 43% of the total filters mentioned, followed by sex with about 73 mentions or 30%, age about 24%, and language with about 23% of the filters mentioned. To capture race ethnicity information in reporting, it was important to note that all 27 of the health system respondents indicated that they capture self-reported race ethnicity information at the registration process. And 78% of them also captured this via their online patient portal. So they allowed for patients to be able to review and then correct and verify the information. The mean number of sociodemographic filters across all the metrics per healthcare system was about 16, and the range was anywhere from 1 to 61. Respondents were then asked via the survey to describe actions that they've taken once a disparity is identified. 12 respondents, about 44%, reported that they have incentives in place, either financial or otherwise, for reporting on equity, 8 of whom 67% had performance goals related to reducing health care inequities or health disparities. When a disparity was identified and reported, 12 systems indicated that the next step would be to implement performance improvement initiatives. 8 systems indicated that they would first conduct an analysis for a root cause, and they would try to determine the contributing factors. And then 5 systems indicated that they were still planning their standard response to an identified equity gap or disparity. In an initial review of facilitators and barriers to implementing system-level metrics, several common themes emerged across health systems. Many systems said that integration of health equity into strategic planning or quality reporting facilitated the tracking process, and this was 44% and 37% respectively. Others said that leadership involvement, that's about a quarter of respondents, coordination among departments, about 10%, and the creation of a work group or committee dedicated to health equity, which is about 11% of respondents, facilitated health equity tracking practices. In the analysis of barriers to implementation, health equity tracking was hindered by a lack of analytic and data support or limitations in those resources. And this was the most frequently mentioned barrier, it was at 33%. Other examples included things like a lack of resources in general to support the work, organizational priorities that were misaligned, and workforce shortages and retention issues around personnel that would contribute to these efforts. So as a summary of the survey that we did, we had several key learnings. I think the greatest takeaway was that this is such a small picture or window into the practices that are happening in our healthcare systems across the country. We have over 6,000 hospitals and over 500 health systems in the country. And so there's much to learn when we think about how are we coming together with a best practice around measuring and quantifying and representing equity gaps within our health systems among our patient populations, and how can we do that optimally? So the variation is an opportunity. And we also learned that among those that responded, as I mentioned earlier, who were likely early adopters of this work, half were in the planning or early implementation phase. So I think thinking about that is really important as we're all on this journey, and really leveraging this momentum to bring us forward together is going to be really important so that we can make sure that these disparities are visible to our health system leadership and then are able to be attached to accountability once we have those metrics included. And then finally, there's just, again, this crucial need to really think about starting a conversation around this topic now at this stage, because so often we hear that the work of health disparities or health inequities is other or extra. But when we include it and integrate it into our executive dashboards, it becomes aligned at the most crucial and integral level for quality, safety, and affordability for health systems. Thank you.
All right, so I'm back and I'm going to moderate some things. So before I get into even asking our panel to introduce themselves, I'm going to just do a very quick sort of rundown of the line so you know who you're talking to. Carol and Kristen just gave kind of an overview, and we get asked this question a lot. Our office gets this question a lot of how do we measure? We're a health system. So I am joined by 4 individuals who are going to tell us a little bit about how they measure. So directly to my left, I have James Williams, who comes from the University of Chicago Medicine. And then we've got Whitney Hagerson, and I'm so sorry if I botch your names, brilliant, and who comes from Providence, Rhode Island, from the Providence Health System. Yep, there we go. And then Shaunalee Roberts, I'm so sorry, who comes from Mainline Health. So we've got, and then Kristen Azar, comes from Sutter. So we've got folks who are deep experts doing this with their organizations. And I'm going to start by just asking a couple of questions. So the first question we're going to start with is give each panelist the chance to tell us a little bit about their health system and their own approach to health equity. And we're going to start with James.
Hello, everybody. I'm James Williams, as she indicated, from the University of Chicago Medicine. I'm a Black man from the South Side of Chicago, and today I have a green suit on with a no collar shirt. And so a little bit about myself. I guess that's a little bit about myself. You can actually go to the next slide. We could talk about a little bit about U Chicago Medicine. So I've had the privilege of working there since 1988. I'll let you guys do the math. We have about over 1,200 licensed beds. Currently, we have 9 ambulatory facilities that are spread out from downtown to the south side of Chicago to the southwest side of Chicago in the Southland region, as we call it. We have 4 inpatient facilities. 3 are in Hyde Park, and 1 is in Harvey, and that's Ingalls. That's our community hospital. About 13,000 employees. We do about 2.94 billion from a revenue perspective, and about $272 million in EBITDA. You can go to the next slide. So just to contextualize this, when you look at our employees, 34% are Black, 35% are white, 10% are either Hispanic or Latino or an Asian, and 1% identify as 2 or more races. And we have about a 9%. In 9% of our team members, we don't have that data. So that's a gap. I always think, well, it's plus or minus that 9%. But then when you look at our inpatient population, you'll see that the Black and African-American population has grown to 63%. White are comprised 28% of our inpatients, Asian 2%. We have no data on 2% of our patients. So that's another gap that we have. 4% identify as 2 or more races, and then 7% are Hispanic or Latino. And then when you look at the 12 zip codes right around our Hyde Park, which is kind of our main campus, it's 77% Black or African-American, 8% white, and 12% Hispanic or Latino. And so you can go to the next slide. And I share that because it helps us to recognize that, you know, we serve a globally diverse patient population. We have a globally diverse employee base in aggregate, and we're situated in a diverse community. And what that means for us when we start to look at the data, which is what this is all about, is that when we stratify that data, we find out that we don't have people of color in the director and above level to the extent that they are in the organization. So it's 27% director and above are Black, Indigenous, or people of color. And so we saw that as an opportunity, given we want to help our employee base be more reflective of our patient population and community. So we identified what that gap was, and we've developed specific strategies, one of which here has 4 pillars. We think about this work, our approach is we want to create a culture of equity, because it's not good enough to just say, hey, we just want to reduce disparities in a patient population that comes within our walls. We really need to think about every person that we recruit, how they are hired, how they have equitable opportunities to be promoted within the organization, that we have an inclusive, just culture where people feel like they belong and they can actually make a contribution to provide medical care. Those people are who help deliver the health care, where we then start thinking about how do we provide that culturally responsive care to the patients that we have the privilege of serving. And then as we are situated in the community, how do we look at the community as an asset? So asset-based community development is our approach, or community-based participatory research is our approach, so that we're looking how to partner, share power, and really change the trajectory of health for the community that we have the privilege of actually practicing in, and really being focused on that culture of equity and how it translates into cultural transformation, equitable cultural transformation, and equitable operations. So I'll pause there. We can go deeper into the Q&A. Thank you.
Thank you, James. And I'll move it over to Whitney. Do you want to tell us a little more about Providence?
Yeah, hi, Whitney Hagerson. I have the privilege of serving as our VP for Health Equity and Medicaid Strategy at Providence. I can pop to my next slide too. We are 51 hospitals across the West Coast, about 1,000 clinics and ASCs. We serve about 6 million patients a year through 28 million, visits. And we have about 120,000 caregivers, about 25,000 providers. So pretty large organization. Again, up and down the West Coast, we are a Catholic healthcare organization founded by Sisters of Providence 165 years ago. So as you can imagine, deep commitment to working and partnering with our communities to address root causes and inequities in healthcare, as well as other social needs. So when you think about our presence, we serve some of the most remote locations in places like Kodiak, Alaska, and then some booming metropolises, right? Seattle and LA. So as you can imagine, our health equity strategy really could not be a one size fits all approach because of the inherent differences of the communities in which we serve and operate. About 42% of our patient population across those 7 states identify as non-white. About 10% of them identify as having a primary language other than English. I was really impressed with your only missing real data on 2% of your patients. I was feeling proud that we have about 90% collection rate, but we still definitely have some work to do. So what you'll hear me talk about today, because we serve such a wide array of communities, is how we've really gone about enabling this work to be hyper local by serving up actionable data that our communities and our ministries can then, act upon. Our health equity work, a little different than what James was talking about. Our health equity work is actually separate from our diversity, equity, and inclusion work, which focuses on our caregivers led by our partners in HR. But as you can imagine, very close collaboration both with them as well as our environmental stewardship team, right? All of this work is very interconnected, both from a policy perspective as well as from an advocacy perspective. So I'm not going to go into great detail. As I mentioned, Catholic heritage, 165-year legacy of working with our communities. We often say that we were doing health equity work before it was called health equity work, which I think is the same across our 4 organizations as we've talked about it. But in 2020, Providence allocated a $50 million fund aimed at reducing inequities. Our board, our sponsors, our leadership team acknowledge that this is not work that can be done off the side of our desks. And in order to hardwire equity, we have to build the systems to make sure that it can be part of our day-to-day work. So I think that $50 million commitment really, jump-started us into saying, all right, how do we make sure that this data is readily available? It had been available, but probably not really widely used prior to 2020. And so we kicked off our Office of Health Equity at that point. A lot of our efforts immediately focused on how do we address the impact of COVID. I was sharing with James just a little bit earlier that in many cases, what that looked like, we were starting to reach out to communities and it wasn't always greeted with open arms, right? Hey, you've been in our backyard for 25 years, 30 years. Like, why haven't you been reaching out? Why haven't we worked together? And it's been a really stark realization within our leadership team, our board, and our sponsors to say, like, this work moves at the speed of trust. And so it is our job to not come with a solution, but come to say, how do we work together? What's most important to you? And how do we help enable that? As we heard earlier, it's the investment in time, people, and money. Yeah, I was like, missing a third one. And so that's really been the way that we've tried to approach this. A lot of our focus started in the ambulatory setting where we have a very large footprint as a feeder into our hospitals. But as we think about some of these new requirements coming from CMS and Joint Commission, it's obviously amplified our focus in the acute care space. So that's really where we're doubling down in 2023. But ultimately, the goal here is to say, how do we make this part of our DNA, part of our culture? This is not a project. It's not an initiative. It's not a sexy buzzword. Like, this has to be part of who we are. And so I'd say that's our biggest focus as we head into the future.
And with that, I'll hand it to Shawnee.
Hi, good afternoon, everyone. My name is Shawnee Roberts. My pronouns are she and her, and I identify as a Black and African American woman, and where I have the opportunity, Caribbean American is what I select. When we talk about granular ethnicity. I serve as the System Director of Health Equity for Mainline Health. Next slide, I'll share a little bit about Mainline. Now, we are a 5-hospital health system in the West, serving the western suburbs and portions of Philadelphia in Pennsylvania. We are a community-based health system. And one of our hospitals is a teaching hospital as well. So we do have some connections to medical schools, although we do not have our own, we're not an academic medical center, we do not have our own medical school. And that's important as we talk about how we train and empower the next generation of physicians and clinicians, which is part of our mainline health strategy. Our organization has about little over 1,300 beds. We see about just under 60,000 inpatient admissions across our campuses, and about 160,000 emergency department visits. We're just under 12,000 employees, and our physician population is about 2,000. And our mission, vision, and values are really focused on serving the community and ensuring that we're providing safe, high reliable, and quality care. What I want to point out about our values is that for a long time, diversity, respect, and inclusion, DRI, had been one of our core values. But in 2021, we specifically added the term equity to highlight and recognize the distinction between what Whitney was sharing, some of the employee-facing work that needs to happen, with a lot of the patient and community-facing work that also needs to happen. And along with that addition of equity into our values, we formally established roles, including mine, to be accountable for this work and help drive and lead a lot of the strategy and the implementation of this work. In terms of where we serve, so the main line has been historically and even currently associated with wealth and affluence. Our service area is about a little over 60% white, and followed by about 20-something% Black. And I'll give some specifics when we go to the next slide, but don't go just yet.
I will.
And we see primarily patients or serve a community that is primarily English speaking, more than 96%. So even though I want to highlight that even though we're looking at less than 4% of individuals that we serve who are not speaking English as their primary language, it is still important to pay attention to those individuals and to ensure that we are meeting their needs and providing the services that we can in an equitable way. And our service area is, as you can see, it's 94,000 median household income. And we're about 50-50 when it comes to gender, male and female. So I want to dig in a little bit into the specific geography of mainline health and why equity is important to us. Because as I mentioned, although we've been associated with wealth and very homogeneous racial makeup, we do serve pockets of populations that have very different community assets and resources and different makeups. So specifically, one of our hospitals, Lincoln Hall Medical Center, sits on the border of Philadelphia County and Montgomery County. And every year, out of the 67 counties in Pennsylvania, Philadelphia County is ranked as 67th out of 67 when it comes to health factors and health outcomes. And Montgomery County, right next door, is often ranked between 1 and 3, first and third, related to health factors and health outcomes. And as I mentioned, our hospital sits right at that intersection, serving those very diverse patient population. I'll go a little bit further to help you understand some of the distinct differences between the populations we're serving. In Philadelphia, for those of you who are aware, there used to be a road called City Line Avenue, and it was called City Line Avenue because it effectively separated the city line of Philadelphia with the suburbs. It is now called City Avenue, and appropriately so. And on one side of City Avenue is West Philadelphia, and the other side is Lower Merion. And I'll just read off some stats for you. Lower Merion is 6% Black, West Philadelphia is 80% Black. The average household income in Lower Merion is $248,000, West Philadelphia, the average household income is 50,000. Life expectancy in Lower Merion is 78 years, and in West Philadelphia, it's 72. The unemployment rate in Lower Merion is 4%, and in West Philadelphia, it's 19%. And 3%, I'm sorry, of Lower Merion residents are living in poverty, where 16% are living in poverty in West Philadelphia. So as I mentioned, Mainline Health is serving these very diverse patient and community populations with, again, varying community resources and varying assets. And even though we don't yet have all of the answers, and we may never will, we're extremely committed to ensuring that the services that were provided are equitable and committed to this work.
Thank you, Shonali. And over to Kristen.
Hey, everyone, I should have started with my pronouns are she and her. I am the scientific director of our Institute for Advancing Health Equity at Sutter Health in California. And I identify as a Middle Eastern American woman, and I'm wearing a bright red shirt today and a smile. So I'm really excited to be here. You heard from me earlier. I'll just share a little bit about Sutter Health. So we're a large integrated healthcare system in Northern California. You can see our footprint here on the screen. We have an extremely diverse patient population. We span rural and urban and suburban communities. We have over 22 Northern California counties, over 20 hospitals, multiple foundations. So we see about 3.5 million patients a year, half of which are a little less than half of which are in panel with us for primary care. We also offer specialty care as well. And we have a lot of rich language diversity as well. So we like to say that our population is a microcosm of the United States, and similar to what my colleagues here have said, really makes it important to think about health equity from a community perspective and the unique needs of those communities, which are very different within Northern California. And also, though, at a system level, and thinking about how can we, as a health system, identify things that are working in one community and maybe spread those learnings in a systematic way so that everyone benefits and all the patients are able to benefit from those learnings as well. We can go to the next slide. So in terms of our health equity work, also like my colleagues, our work actually began almost a decade ago in thinking about how we could look at all the work that was being done locally within our hospitals and clinics and think about how to leverage the power of our system and bring those efforts up to the system level in some kind of a unified strategy. And so all that work evolved and ended up resulting in the Institute for Advancing Health Equity, which we officially stood up in December of 2020. And so for IAHE, we have a framework that we use, which I have here on the screen. And we start with metrics and insights, really thinking about how to use our data. We apply the scientific method. We want to be grounded in the data and the evidence. So, and that brings us to the conversation today is as we began that work, inevitably the question is, well, what's the optimal way to measure and to be able to track some of these indicators? And so we use that data not only to be able to track and indicate, but to inform solutions. And we really want to shift our focus into this piece because we've spent collectively many years, I think, admiring the issue. And this morning, one of our speakers showed just that the disparities have not changed in decades, right? And so a lot of the conversation we have in our health system is how can we move towards solutions and innovation around closing equity gaps? And so that is part of what we are tasked to do, but we can't do either of those things without being a trusted partner. So another very important area of our framework is advocacy and community and really thinking about partnering within our health system, all the unique stakeholders and internal communities, but also with our patients, also with the communities that we serve, in thinking about how we measure, how we interpret those data, and then how we incorporate those data into solutions that can actually make change and be scaled throughout our system. But also importantly, we have a really strong mandate to think about how to share that knowledge externally as well. And finally, workforce readiness in thinking about how we can bring in our care teams, our clinician leadership into this work, how we can make sure our care teams are prepared to care for diverse patients, and how we can provide opportunities for training for those that come from underserved backgrounds. And so I'll go quick because I know we're kind of running on time. But one way that we do this is we've developed or are developing what we call our IHE Action Network. And this is kind of the nervous system that we're developing to plug in at the various levels of not only our organization internally, so we have our internal advisory council, for example, all the VP level leadership of all the key functions within our health system, like quality, population, health, research, operations. But also we have focus area councils to tap into frontline providers and care team members who are change makers in our focus areas. And then our community collaboratives that we're working with our community health teams to develop. And finally, we have an external advisory council of some national thought leaders who have graciously given up their time to inform our work and to help us to be better. And I should also mention that our institute is within our quality division. And so we're aligned internally in a way that will allow us to integrate this work into the fabric of what we do.
All right, I'm going to move on to the second question. I want to make sure we get through all the content. So each panelist may only just provide a couple of highlights. There's much more they could say, and I know they would love questions after the session. So we're going to talk a little bit about something that's unique, maybe about each of these systems, or a key aspect of the way that they track and monitor their progress. And I'll start with James.
Go to the next slide.
Mhm.
So just picking up on the last comments that I had, the work is really strategic, equitable transformation. So how do we integrate equity across the entire organization? And it starts with our Vision 2025 board, strategy plan, the 4 pillars I shared before, but then one click below that, there are annual operating plans that the entire organization looks at. It has our mission, vision, and values. Equitable systems are what we want to create. Our previous values had diversity, but as of May 25, embody equity as a core value of our organization. It didn't hit these slides because I had to send them in early. But then there are 5 pillars on the annual operating plan. So people, really not just diverse organizations, but then how are they equipped to provide culturally responsive care? And then how do we stratify data from a key metric perspective? From a patient experience perspective, the focus is on how do we create trusting therapeutic relationships with patients so that they can share in the decision-making and then manage their care when they're outside of the acute care setting. From a quality and safety perspective, it's really focused on how do we leverage data and analytics, and I'll show that on the next slide, so that we can visualize disparities and then move to the solution space for solving for those disparities. From a value and finance perspective, we're really focused on how do we partner with community health centers, federally qualified health centers, safety net hospitals, and then leverage both our dollars, philanthropic dollars, and governmental dollars to create what we have collaborated on, which is a Southside Healthy Community Organization to address strengthening the ecosystem outside around the hospital. And then the last piece around growth is really focused on how do we start to, as we digitally enable healthcare, how do we ensure that that's done in an equitable way? You can go to the next slide, please. And so what we've done inside, just one click below that, is we have leveraged Tableau dashboards for our clinical priorities and then integrated filters around patient demographics so that we can democratize the data for quality leaders to use to identify and then start developing health equity plans around disparities that they see in their data. So I'll pause there. Oh, this is the next, the next slide is specifically, this is a slide of how the leaders in our diabetes, in our ambulatory quality focused on diabetes, and then they went another click below. So the other pieces were like at the quality committee level, but then once you get into a different service line, those individuals are responsible for even looking at the intersection of other demographics. So is age, is demography, is payer. What are the other intersectional demographics that we can identify disparities and then begin to address them? Now, go on.
That was brilliant. Thank you. I know we're to Whitney.
Yeah, and I apologize. I also should have shared my pronouns like she, her. I identify as a white woman. Red hair, red dress, probably some red cheeks, some sweaty up here. Bear with us. Yeah. So, I think there's a number of things that Providence has done to help enable this work. But one of the things I'm most proud of is the democratization of our data. So what I'm going to share with you is kind of this action-oriented analytics that we use that is kind of a 3-step process. So this first step, what you're looking at here is we started by stratifying our existing patient safety and quality measures, right? So what you can see here are 9 ambulatory quality measures. That little graphic you can see on the right-hand side are the filters that we can add. So we can look at this data by race, by ethnicity, sexual orientation, gender identity. The colors that you see there are actually indicative of a homegrown health equity index that we have that enables us to identify things, intersectionalities, because it's not as simple as just looking at race or just looking at ethnicity. I don't have enough time to go into that, but happy to geek out if anyone's interested in that after the fact. Across the right-hand side, you can see that I've hid filters, but basically we can look at this data across our 7 states and 51 hospitals, 1,000 clinics, or we can drill down specifically to a given practice, a given provider, right? So being able to say, this doesn't happen in my practice, well, we can actually just take a look at it and see what's actually happening in our practice and where should we be spending our energies. So if you go to the next slide, basically, again, kind of the click in, right? So say we want to identify or we want to work on addressing hypertension control in the Black and African-American population in LA. Well, there's work that we need to do in our communities to address the root causes of inequities. And there's this immediate work that we need to do now for the patients that entrust us with their care. So what this enables us to do is actually pull a list of our patients that in this case, in that example, Black and African-American patients that maybe have not reached hypertension control. So we can do the immediate work of saying, all right, how do we connect you with a clinical pharmacist? How do we connect you with a community health worker to start to address your immediate needs? So it's a both and, right? There's the longer term work that we need to do to address the systemic and root causes. And what can we do today to make a difference for the people that trust us with their care? And then the last kind of click through of this action-oriented analytics is our ability to then track and trend data over time, right? So what you can see on your left-hand side of the screen is just our quality measures stratified by race and ethnicity. So it's a slightly different view than what you saw earlier, but it's trended over time. So we can say, is quality going up? Is quality going down? On the right-hand side, though, what we can do is hold a comparison group constant. So it may be the white population, it may be another population, depending on, what filter we're looking at, but holding that population constant and actually starting to say over time, is the inequity decreasing? It's not enough for us to say we've improved quality in our patient populations. It's really saying we don't want to see, a rising tide raises all boats. What we want to see is more progress in the populations that we're focusing on and actually seeing that inequity get smaller over time. So I think this is one of our, secret sauces, is being able to say, like, how do you make this data available so people can make sure that they are taking a data informed approach and they have a tool to help with continuous process improvement along the way.
And Shonali?
Awesome. So I'm going to start with how we have operationalized our work. And then the next 2 slides will share 2 ways that we look at the data. So part of what ignited our work in equity was to set a priority, specifically a goal, that our clinical departments, service lines, clinical programs, what we call our CEWs, clinical environment work groups, that they all established an equity priority in their setting. We have 16. And that they move beyond that to establish a metric that they're going to improve, and then also an action plan to address whatever disparity they may have identified. So when we started this work a year ago, what this slide is showing is that we were at 37% of our 16 teams having that in place. And as of the end of Q4, we're up to 81. Down in the bottom is showing a little bit of how we were able to achieve that. And some of what is on this slide was already discussed up with this group in terms of building relationships with the quality teams. Equity also sits in quality at Mainline Health, and building relationships with our clinical partners where they understood the intersection between quality and equity and how it makes sense for them in their specific line of work. And we did that continuously. It wasn't a one and done. Through a regular cadence of meetings. We also leveraged our interdisciplinary committee called the Eliminating Disparities Work Group, Health Equity in Action. It's a little bit of a mouthful, EDW for short. And this is really where we're bringing together our clinical teams, our quality teams, our community teams, our employee diversity, respect, inclusion arm as well, to have conversations around what we are or are not doing. And a lot of the focus of that group is on, if you go to the next slide, where we look at our data. So we have two ways that we monitor and measure activity from a health equity perspective. This, what we call our disparities data profile. I know the slide says 80 plus measures. We're now looking at over 100 measures that are important to the organization from a quality and safety and patient experience perspective that are stratified by key demographic indicators. So the columns at the top reflect race, ethnicity, gender, zip code, behavioral health status, sexual orientation. I may be missing a couple. And the rows down at the bottom are important quality measures like length of stay, readmission rate, mortality rate, even ED super utilization, and ED treat and release visits. And as you can see, the document sort of ranges from green to yellow to red, which just indicates where we're doing better and where we have some opportunities. What's important to note is that this profile is where we monitor where there may be disparities within the organization and within the care that we might be delivering. This does not equate to there's active work happening across all of these 100 plus measures. Where that begins is the next slide, is in our, similar to James, we use Tableau as well, is in our STEEP reports. And many of you may use the safe, timely, efficient, equitable, effective, patient-centered reports. But what you're seeing here is a snapshot of our equitable report, which is where all of our equity measures that our clinical partners are actively working on roll into, so that at a system level, we can monitor progress on where we've identified disparities, where there are interventions in place, and how that is moving forward. This is across all of our campuses, as well as our system at a system level, and it's also includes baseline data, target and superior data. So we know which direction we're hoping to move and where we are currently. And some of the examples, I know you guys can't see it, but some of the examples on this slide relate to 30-day readmission by payer, patient satisfaction scores by race and age. I think there's also OB. So we're looking in our OB space around substance use disorder and opioid use disorder, and where we may or may not be equitably administering urine drug tests or screening as it relates to that. So that's something that's important to us that we've been able to move the needle on. We're also looking at primary C-section rate in our OB space and hoping to, again, as Whitney mentioned, decrease the gap there. And I believe finally, there's some emergency department metrics around patient experience again, and how we can improve the courtesy of our staff by patients by their self-reported race, as well as food insecurity screening, ensuring that we're screening patients coming into the emergency department and looking at our high utilization rates. So again, the difference between this report and the first that was shown is there is active work happening in our clinical departments as it relates to this. The first report is where we're monitoring where we may need to perhaps align some work and stand up some efforts to address disparities.
And Kristen?
So I'll be brief. And just really appreciate hearing about the wonderful work of my colleagues here. I agree. I think the multi-level analytic platform is really important, and I will go into that in my next slide. But what we did was convene a work group to really think about how we could do this at a way where the roll-up at the highest level is visible and then indicates kind of the place to then drill down to. And it surfaced some questions for us about how we think about quantifying a disparity or an equity gap. Some of the pieces that we're working through now are, you heard intersectionality mentioned. So can we think about incorporating multiple different sociodemographic domains when we look at the data off the bat? And so you see here an example where we have created also a homegrown metric of looking at race, ethnicity, and then also median household income as geocoded by this at the census tract level, as well as sex, and trying to use that in a way to create a what we call our outcome equity ratio, where we look at the proportion within a given subgroup in that matrix compared to the overall population and the proportion that do not meet a metric. So you would expect that if they are equal at one, that you would have a situation relative to the internal population. We're not talking about the external benchmarking. You would have equity. And then if you have something where it's over one, it would indicate an opportunity. And so what we're working on now is thinking about how we can socialize that. Is that something that will work within our health system to drive action? And we have two different options for this, thinking about with those outcome equity ratios, are we trying to look at some kind of a meaningful difference? And that's a question of what should that be when you're describing an inequity? Is it 5%? Is it 10% of a disparity? We're also looking at, on the other panel, should we make sure that all of the subgroups meet a certain level of performance? So for our quality metrics, we often use the P90, for example, for HEDIS national benchmarking. Should we make sure that we count the boxes of the groups that meet that or don't? And so those are some of the questions that we're thinking about, is how do we even begin to characterize. On the next slide, please. And actually, I have a poster if you're interested in going deeper about this. But so this is how we've operationalized it in reality. We have a dashboard that we put together we settled in this work group on 4 ambulatory, 3 acute care metrics. And we picked metrics that were already being tracked within our quality teams, and also that had data around the need and the existing disparities to compel us to want to track these for our populations, given our patient demographics. And so you can see we chose colorectal cancer screening, breast cancer screening. We chose diabetes control, hypertension control, and then for the acute care, sepsis mortality, readmission, 30-day readmission, and then C-section rates. And so with our analytic platform, I just have a high-level overview, but happy to go into detail later. You can see that we've used that first approach with our homegrown index to roll it up to a number, and then used 10%, so 5% variance to be yellow, 10% to be red. And so you can see kind of at that highest level roll up on the screen. And then we're able to drill down again to our hospitals and our ambulatory centers to figure out how different groups are doing, and then have different views to look at longitudinally changes in the metrics.
Thank you, Kristen. All right, so you've heard different, I'm going to recap right now just because different health systems, different stages of sort of the journey. Everybody seems to have a dashboard though, right? So I think we can acknowledge that dashboarding is a fairly significant part of how each of these organizations is tracking their own progress, but each of them treats them a little differently. Couple of homegrown health equity indexes and indices, if you want to talk to those folks later. But then, folks tracking by site. So looking at things differently site by site, a couple of indices looking at intersectionality, thinking about where a patient has a set of characteristics that may interact with another set of characteristics that changes their healthcare experience and what to do about it. You see in some of these dashboards, individual providence, looking at individual patients, mainline looking at the different, where there is action, where there might need or be opportunities for action. So then metrics. What do you do about it? So the next question, thinking about accountability and incentives to close disparities. James, over to you.
There we go. So the accountability starts at the board. So we get our equity plan approved by the board. And then we also, we have a suite of measures that transcend just the patient outcome. So really thinking about the people and community metrics. And then we link those specific targets. We had a Vision 2025 target for the organization. So we had an equity plan 2025 to mirror that. And then we link executive incentive to hitting those targets across multiple metrics. And then from an HR perspective, we've integrated rewarding people and teams that are equity champions within the organization, just kind of keep that fire going.
All right, and Whitney?
Yeah, ours is pretty similar. So we have a strategic plan. You can see here on the screen. We have 6 what we call measures in common, which ultimately determine bonus structures. Health equity is one of them. So ultimately what we look at is the percentage of our accountable entities. So whether those are our lines of business or our divisions, what percentage of them are actually driving measurable reduction in the inequity that they chose. Again, it varies from Alaska to LA as it should. And then ultimately that determines our performance on our strategic plan and subsequently incentives for leaders and other caregivers. And then specifically, we use, similar to what James mentioned, we have a pretty robust governance structure that actually puts health equity councils down to the ministry level that ultimately roll up through our system and into our board and sponsors.
Shanley?
Sure. So very similarly to James and Whitney, our health equity accountability starts at the board level, specifically at our Quality, Safety, and Equity Committee of the board that approves our initiatives as well as our strategic plan. What you're seeing here is the IHI Institute for Healthcare Improvements framework that Mainline Health has adopted to help drive our health equity work. And it's very similarly to what James mentioned. It's above and beyond patients and community, even though it does very much include that. But speaks to our people as well as the determinants of health that may be happening or impacting patients outside of the healthcare space itself. Specifically, our strategic plan includes language around equity, and you can see in goal 2, which is around advancing the health and well-being of the communities we serve. That initiative B, or objective B, is to build trust, identify and eliminate disparities in care with the understanding that structural racism has affected confidence in the healthcare system. And then from that, it cascades down into what specific level initiatives with accountable team members and leaders and groups might be accountable for that specific work. Do I have another slide? Okay.
Kristen,
Yeah,
yep.
so I'll just add, health equity is a key priority at Sutter. We are undergoing actually a revision of our mission, vision, and values as we have a brand new CEO, Werner Thomas, who's been wonderful and very supportive of this work. And so that is definitely a conversation that's going on right now, and thinking about how can we integrate accountability within the system, both not only within our strategy and within our mission and our vision and all those pieces, but we have some physician groups right now experimenting with financial incentives for closing gaps around, for example, hypertension and diabetes, and taking our scientific lens and trying to understand how that then impacts those gaps is going to be really important to then building the momentum to integrating those types of practices into our practices going forward.
And I'll just add, I'm learning that, James, your group is, or your organization is focused on recognizing and rewarding equity champions. And I would love to talk to you about that because at Mainline, we're exploring that as well. And it's always good to learn and share.
Which is a fantastic segue to actually, so we're going to do rapid fire, barriers and facilitators, because we only have like a minute. So James, biggest barrier, biggest facilitator, like so fast.
Not the pressure is on. I mean, the biggest barrier is just really organizational change. I mean, you have to align the entire organization around the body of work, and everybody is up to here with what they already have. So our strategy is to integrate it, help them be better at whatever they're doing, HR, people, supply chain, whatever it is. We learn what they need and help them solve problems.
Whitney?
I'll say our biggest facilitator is our people. I think people are really committed to this work. I think it's restoring joy in practice for a lot of our providers. This is why they got into medicine to begin with. And I'll say our biggest opportunity is probably the financial quantification of inequities and our efforts to reduce them. We need to change the conversation about this being a moral imperative to this being a business imperative, because we know that it is. And so if anyone's doing that really well, please find me. I want to pick your brain and hear all about that.
Shonali?
I'll say for us, it's been the biggest facilitator has been our leadership support, starting with our CEO, Jack Lynch. And having the accountable leaders, because he is so committed, having the accountable leaders be also committed to this work and designated in that regard. And I'll say very similarly to James, the biggest opportunity has been the resources. So this support for the staff and the designated staff time to help kind of drive the improvement in this work. This is different work than we have ever done before. And this is a different way of looking at how we provide care. So that has been a challenge, and it's something that looking for help to do as well.
All right, Kristen, last word. You get it.
Yeah, I'll echo everything, and the survey actually said it very well in terms of barriers to facilitators. But I do want to say, James, that's at the heart of it. I think change is hard. I think this is a different way of looking at our data, our patients, asking the right questions. And so I would say that's probably at the heart of it, is just really bringing people along and demonstrating that this is not optional. This is crucial to providing the most optimal, best care we can to our patients.
All right, so we are I'm 1 minute over, but I want to just close out. I want to thank our panelists. I want to thank our audience. Thank everyone for being here. This is a great example of health systems doing work that they are all learning from each other. We all have the opportunity to learn from each other in the space. And I know there are a few folks who spoke on our panel today who would love to connect with other folks who want to be in a space where we are sharing and understanding how health systems are measuring their progress, how we're showing our progress, how we can learn from each other to quantify disparities and the cost, the value of action. So with that, thank you all, and I will release you.